3. Good afternoon and welcome to another edition of Let's Talk. As usual, we are delighted to be with you on the airways of Second Advent Radio and airways of Second Advent our YouTube channels, SLC Church channel and SLC Adventist. Wherever you are around the world, it is our delight to welcome you to another edition of Let's Talk. We are this afternoon discussing a very important subject, palliative care. That is an area that is growing in importance. I'll explain in a minute. Before we do so, and before we introduce our guests, we would like to invite you to have a little prayer. Shall we? Almighty Father and our God, we thank you for the opportunity and privilege to share with our friends in the radio lands and those who are joining on our social platforms. We pray for your guidance and your wisdom in Jesus' name. Amen. I remarked to somebody this morning that I regularly visit the shut-in members around the conference, and it is a real delight to encounter individuals. We do have a few persons who have reached successfully the age of 100 plus. And it's a joy to talk with them, those who are still collective in their right minds. Last year, I remember, for example, not last year, this year, on the island of Montserrat, I visited two persons who were 99, and I was surprised to find one of them in her kitchen cooking, and another one who was out on his porch and told me he just came out of his garden. And I thought at 99, that's pretty good. There are others, several others, however, who because of circumstances, bedridden. In fact, I have come across very young persons who have conditions that require special care. I know when you get older, the chances of us requiring special attention is important and increases. But for individuals who have life challenges that require special care, we want to consider such things. With us this afternoon is Dr. Natalie Greaves. Dr. Greaves is not a stranger to Let's Talk. She spent the month of February with us. Many of you, I believe, would remember the wonderful series we had in February dealing with cancer, all sorts of cancer. We are delighted to have Dr. Greaves back with us. This afternoon, she is going to be talking not about cancer, well, maybe she may make a reference to it, but we're going to be talking about palliative care. She is also an expert in palliative care. In fact, I think this is, Dr. Greaves, you can correct me, but I believe this is one of the specialty areas. And so we want to just say welcome to Dr. Greaves. It's a delight to have you back on Let's Talk, and good afternoon.
Thank you. Good afternoon. Thanks for having me. So in terms of where I position myself in palliative care, it's in community palliative care, what we call primary palliative care. So palliative care that is delivered in the home setting. And I also have the pleasure of being a palliative care educator at the University of the West Indies at Cave Hill campus. So I'm happy to talk about palliative care. It is an area that I've spent almost 20 years thinking about palliative care and how to get it started and delivered in the Caribbean in a way that people can understand, appreciate, and afford and access. Yeah.
Wonderful. Well, Dr. Greaves, I want to begin this way. We did plan to have this program back on October 12th. As I look back at my calendar, I realized that the challenge was that October 12th I was unavailable. We did take a little break from Let's Talk on that particular Sabbath afternoon. The second Saturday in October is World Hospice and Palliative Care Day. So I have two questions. First, what is the purpose of this emphasis? Why a day for hospice and palliative care? And secondly, is there a difference between hospice and palliative care?
Okay, sure. So why a day? Firstly, you would notice that almost every day in the calendar has a meaning or a special day of emphasis,
Yes,
and
I've
it's
noticed
something that
that.
yes, something that pretty much happens. But particularly for those things that may be lacking in regional recognition or global recognition, there is need to broaden persons' understanding, awareness, etc. So that's part of the reason why there's a World Hospice and Palliative Care Day. In many regions of the world, persons may not understand what hospice care is, people may not understand what palliative care is, and there are sections and segments of the community that don't have access to these services, and they suffer needlessly. And it's a way also of advocating for service provision by communities that can help to provide this compassionate form of care. So whether those communities are faith-based communities, other social activist communities, or the government itself. So that's a big part of what World Hospice and Palliative Care Day is about raising awareness about what it is, how to access it, the benefits, and the need. And we think that if people are aware of what it is, then they can ask for it. So let's take a step back and then maybe define the two. And depending on where you are in the world, the two words may be used interchangeably, but at their root, they're not the same technically. One can be seen as being a subset of the other of sorts. One of the words that is most commonly used, you'll find now, is palliative care. And so when we speak about palliative care, we're thinking about, one, if you're taking notes, that form of care that's provided to persons who have life-threatening illnesses. Some definitions may put in brackets advanced progressive illnesses, and it's the emphasis of that form of care is on quality of life. And it's a holistic form of care. It's provided by healthcare practitioners, it's provided by family members, etc. And because it's holistic, it's going to take into consideration a person's spiritual needs, their emotional needs, their physical needs in various domains. And it has at its root the ability to make a person comfortable. So palliative care comes from a root word that means to cloak or to cover. And it's not necessarily meaning to hide. It's not like putting on a hoodie or something and you're hiding something bad, but it also means to swaddle and comfort, like you would comfort a baby, or comfort someone in need. So you can think of palliative care as that cloak or that cover that seeks to comfort. And it comforts the patient, it comforts their family, and it takes into consideration pain management is a big part of palliative care. So alleviating pain and suffering, and also addressing symptoms that persons might be facing because of their underlying illness. With palliative care, it can start when you have a curative condition, a condition even where cure is intended. But if the condition changes into a trajectory where cure is not possible, palliative care does not stop. It almost becomes the dominant form of care. And if a person is to pass away or to die, palliative care continues for that family into the period of bereavement. Hospice care tends to be that form of care that is delivered, especially in the American setting, when a person has not only a life-threatening illness, but an advanced progressive life-threatening illness where cure is no longer seen as being possible. And so hospice care does something similar, but we would say maybe within the last 6 months of life. That's what you would especially see in the American system, and it takes into consideration the phases of active dying, etc., and it supports the family afterwards as well. So if I were to draw a graph, I would say remember that palliative care can begin at the point of diagnosis, even when a person is going through a curative illness. But as the curative intent becomes less likely to become cured, the palliative intent becomes more, and the palliative care intent continues into the period of bereavement. And hospice care is really very close to the very end of life.
So
Hope
let
that
me,
helps.
yes, certainly. I am, that's pretty clear. But a question,
Sure.
while you were talking, this came to my mind. So is occupational therapy a form of palliative care?
Oh, okay, sure. So occupational therapy is a specialty and a discipline all on its own. But what happens with palliative care is that palliative care is delivered by a multidisciplinary team. So people with varying expertise that need to help a person cope. So I know we're on Zoom, and I don't imagine that some of your tools are working, but imagine I'm drawing a circle. I don't know if you can see it, but imagine that. Can you see a circle that I'm drawing on the screen with my mouse? No?
Not yet. Try again.
Okay. Okay, no worries.
You
But
could try again. I just
okay,
enabled something, so let's see if it works again. I'm not sure.
okay.
Okay.
In Okay, I'll forget it, but I'll just say, imagine my hand is drawing a circle, and the
Mm.
person is at the center of that circle. The person may have a physical need that requires them maybe to learn how to walk, or maybe it might need them to learn how to use a tool to help them with their eating or their swallowing, etc. And so the occupational therapist may be able to assist with that. And the occupational therapy also brings in a lot of psychological support as well. So the occupational therapist might be able to assist that person with their activities of daily living and transitioning through how to move their bodies in particular ways to have their best level of functioning and to help their families to care for them. But palliative care, the person may also have a need where they may need help with their nutrition. So a nutritionist may be involved in terms of how to make the meals, what should be the content of the meals. And maybe if they have a particular underlying condition, maybe they have a renal failure, or they have end-stage renal disease and they're on dialysis, their nephrologist may need to be involved. Their oncologist may need to be involved, the cardiologist, etc. And then on top of that, you may have the palliative care person helping to coordinate it all and to address those particular symptoms that need that cloaking or covering or that are affecting the quality of life. And in addition, then you can also talk about your spiritual support, like your chaplain, etc., your psychological support from your psychologist or your life coach, that kind of a thing. So occupational therapy, although it's separate and it has its own discipline, occupational therapy may be a big part of palliative care, likewise physiotherapy and other allied health specialties.
I'm getting the idea that when we talk about palliative care, therefore, we're not just talking about a single individual delivering care. We're talking about a team.
Very much so.
Okay.
Very much so. It's a big coordinating effort because it's a holistic form of care and it's seeking to improve the quality of life. So if you're doing a palliative care consult, one of the things you want to know, yes, you will take into consideration the medical history, but you'll take into consideration the person's level of functioning. You'll take into consideration their nutritional goals. You will take into consideration their goals for themselves. What are the things that they need to achieve? What are the things that are important to them? Sometimes people need help with things related to legal aspects. So even like will preparation or various other kinds of things. And you coordinate those services to make sure that everything is done. While also, if the coordinating person is a physician like myself, you're making sure that their pain is covered, nausea, any vomiting, any sometimes people may have issues with pressure areas on their skin or anything, that you're also covering all of those symptoms as well as best as you can and tapping into whoever you need to make sure that everything is done for the patient.
Okay, I'm getting a very good understanding of where we're going now.
Okay.
I was going to ask earlier,
Uh-huh.
this is almost not necessary, but somebody maybe where I was before, so let me go ahead and ask, just so that I can be sure that the understanding is correct.
Mm-hmm.
I get in a serious accident and become incapacitated.
Okay.
I may, and the emphasis there is on may require palliative care depending on the extent of the injury and how life-threatening and transformational it may be.
Mm-hmm.
If on the other hand, I'm diagnosed with, let's say, terminal illness and the doctors have done all they can and they say, listen, you're going to die in 3 months, there's nothing else we can do for you. What I may need is hospice care. So is that the
That's
kind of...
correct. But I'm just saying also that that person may also, the last situation will also benefit from palliative care because hospice care is kind of nested within palliative care at the very end. So yeah, and in some countries you will find that because of stigma and misunderstanding and misperception, so sometimes in francophone countries you may find that people may not want to use the word hospice as much because hospice has another connotation related to incarceration and poverty and various kinds of things. So depending on sometimes on the country, you will find that people may use the words differently, but at its root, it's a service that's not going to abandon the person. It's going to seek to address their needs in a holistic fashion. It's going to be seeking to improve their quality of life and making sure that they matter, that they know that they matter up to the very last breath, and that they're taken care of. That's one of the things that, that's almost like a direct quote from one of the founders of the modern hospice movement, a lady by the name of Dame Cicely Saunders. And that if they have pain, that pain is managed completely. And if that pain has physical aspects, if it has psychosocial aspects, if it has emotional aspects, etc., that holistic approach is being adopted. And you will see that in hospice, and you will see that in palliative care. Related to the person who has the injury, the car injury, the accident, and their disease is not progressive, it's not life-threatening, etc., they may benefit from things like another form of care called physiatry. They may benefit from physiotherapy, etc., etc. But if the pathway of their life expectancy is not likely to be threatened or anything like that, they may not need palliative care. They may need their coordination from a different source. But sometimes where resources are limited and resources are stretched, there will be nothing that would stop a palliative care team from not caring for that person with a chronic illness that's not going to necessarily result in their death. But the person with the accident, I can foresee sometimes if people are not mobile, if their care is not addressed properly, they may have challenges with their skin. They may have challenges with ulceration. They may have challenges where they get infections unnecessarily. And these kinds of things can then threaten their life when it doesn't need to. Yeah.
So there is this, I'm not sure what it is. What's the culture or the attitude towards this situation that I'm going to highlight right now. I'm not sure what it's like in your country, but there's an increasing number of what we call senior citizens homes that are being established these days. That's just my observation. And I am thinking, as I listen to you, about the comprehensive nature of palliative care. Traditionally, at least when I was a child growing up, the government had the senior citizens home, you know, and ultimately people called it poorhouse. It developed that stigma where if you are old and you have nobody to take care of you, they turn you over to the government and they put you in this place where all these old people are and they're going to die, and it became known as poorhouse. So just the idea of a person going there, you know, the stigma that was associated with it, to the point where lots of people prefer to take care of their elderly persons at home, and people felt it was a disgrace for somebody to turn their person over to the government to provide that kind of care. But nowadays, there's an increasing number of senior citizens' homes that have been established. If I hear you correctly, I know we weren't talking about what is supposed to happen in these homes, but I'm just thinking that what these homes probably should be providing is palliative care with the range of services that you spoke about.
Yeah, so care of the elderly in terms of gerontology or geriatric care does take into consideration what happens when a person has a progressive life-threatening illness and involves palliative care. So you will find that in Barbados, some of the senior citizens' homes will say that they provide palliative care as well. So in other words, if you know that your loved one has a progressive illness, so say for example they have form of dementia that's going to progress and where they may have difficulty with swallowing and so forth and moving around and communicating and so forth, these homes are saying we have the capacity to make sure that your relative will be taken care of properly. If you have a senior citizens home and they're offering palliative care, they're saying to you, if your loved one has a progressive cancer, cancer that is not in its, that may end up in even if it's not going to end there just right now because the person has just been diagnosed, they're saying that they're not shying away from that form of treatment. If you have a relative and that person has chronic renal disease and they need to take special medications and they need to be on a special diet, etc., there are some homes in Barbados, some senior citizens homes that are saying yes, we also provide comprehensive palliative care, etc. And some of them do a really, really, really good job in that they make sure that they have, in addition to the nurses, etc., the physical layout of the rooms might be slightly different. Maybe they have the wheel-in bathrooms, different things that the occupational therapist might advise to keep persons happy, keep persons with a sense of community around them while also having the necessary medical cover and allied health medical cover and nursing care and various other kinds of things. So yes, and what's happening also in some of our islands, and I think of Cayman Island in particular, there are also dedicated spaces, for example, hospices, where if a person is very close to the end of life and the relatives are not able to care for them, or the relatives prefer for them to be cared for by a multidisciplinary team, a team of experts, you can transition your relative there. And there are these standalone units, usually very beautiful, very peaceful, with all the necessary access to the multidisciplinary team to take care of the relatives. What we have in Barbados, we don't have a standalone hospice as owned by the government, owned and operated by the government, but we do have teams of physicians who go to persons' homes and help to provide this kind of care. So they organize the nutritional support, the physiotherapy support, the doctors, etc. They visit the home before the person is released, discharged from hospital, help the families to set up, help them to get like hospital beds or oxygen or whatever they need that is within reason. Because not everything can still be handled in the community setting, but as long as the person is an appropriate candidate for the hospital setting, then for the community setting, you transition them home so that they can be with their family members in their setting that they want to be, if that is what they want and the family wants, and everybody can coordinate to make it happen. So in Barbados, we have a very strong hospice at home service. Trinidad is probably one of the most progressive in terms of access to end of life and hospice and palliative care facilities in the region. So they have in their regional health authorities, they have hospices in their regional health authorities, they have home palliative care teams, and they also have the Cora, it used to be the Cora Chest Hospital, but the Cora Hospital has a palliative care unit. They actually have a national palliative care unit that is available to persons in Trinidad, and they have a very active palliative care society as well. And I would say that lots of churches support palliative care, formation of palliative care historically and even in the present. So certainly the Roman Catholic Church has been very strong in the formation of the palliative, or the support of the palliative care movement in Trinidad. And in Barbados, the Seventh-day Adventist Church would have sponsored the first palliative care conference. They would have for several years, the first palliative care service, outpatient service, was actually at the site of the, for those who know the Britons Hill area, was at the Caves Clinic and the Caves Nursing Home would have had palliative care inpatients, etc. And that whole service in Barbados would have been birthed. Some of the first meetings of the Barbados Association of Palliative Care would have been sponsored by FACE. Yeah, I hope that helps. I went on a bit.
Yeah, certainly, because I was going to ask you about the whole concept of how we relate. I know palliative care is not restricted to the elderly, but I think that that is a significant part of it. So I was going to ask you about because this is, of course, is a Christian program, in terms of our responsibility towards providing quality care for our seniors. I heard in the news recently that there were several persons who died in the senior citizens' home, the one that is operated by the government, and nobody came to claim them. So it's almost like they were abandoned. I heard on the news as well on BBC this time some alarming statistics coming out of Japan, where over 30,000 persons were found between, when did they say, a period of about 9 months. They discovered so many persons who died and spent at least 1 month in their house before anybody knew that they were dead. And I thought, as a Christian community, um, don't we have I mean, you're a physician, you're also a woman of faith, but in terms of our response to seniors, when a person gets old and very old, they begin to lose friends because, especially if you live for very long, all of your peers and associates may die, and you may be the only one alive. What, how should a church respond to seniors and in terms of providing care? And I'm thinking that this is maybe a part of palliative care because the community kind of affects the social dimension to it. I'm maybe making up something here, but
No.
respond to that.
Yeah, so a couple things were running through my mind as you spoke. So we know globally more than there's something called serious health suffering, serious health related suffering. More than 40 million people every year die without receiving the kind of care that they need, that would relieve suffering. And I think that as faith communities, regardless if they're Christian or not, lots of faith communities are very concerned with relieving suffering. So I think as faith communities, we have a responsibility to play our part in terms of relieving suffering. So whether that's suffering caused by isolation, whether that is joining or being part of advocating for persons to have essential care, or if our faith community is strong enough and powerful enough or has enough resources to assist in the provision of care, I think that we should. There is a whole concept of something called compassionate communities and helping persons to reduce the isolation that people feel when they're going through life-threatening illnesses or caring for a loved one, and then also acknowledging loss. So even in terms of occupational wellness and safety in the workplace. So you have a territory that you manage. You may have pastors, you may have congregations, you may have workers, and people experience loss, or they're hurting, or they have challenges with their health, etc. And they may themselves be faced with advanced progressive illnesses with themselves or with their families. How can organizations, how can communities, how can families, how can workplaces institute these little almost like nests of compassion and care? So right now there's a big international conversation about creating compassionate communities that say, hang on, we as humans, we are connected, we hurt. When we hurt, we need support. If we are hurting, we can say that we are hurting in these particular ways. And if we need support, we can receive support in these particular ways. And what that might look like in each culture may be different. So in the Caribbean culture, that might mean some people may be still accepting of someone who is a stranger coming into their home and caring for them, etc., etc. In another culture, it may not necessarily be that, but it's figuring out what does compassion look like in your culture. And I think that churches, other, well, I don't want to say as churches, I'm not talking about the physical building, but I'm talking about the collection of people.
Yes.
I think we have a responsibility to think about how can you ease the darkness that people face. And churches are well placed to be part of the compassionate movement. Yeah.
Now, thank you so much for responding to that. Um, I don't want to yet. I'm seeing some ethical concerns may be involved, but I want to go first to just again to be very, very clear that the level of which palliative care um is involved. How is palliative care different from the regular medical care that I may receive at a hospital or some other medical facility?
Sure.
If I have a senior citizen and they take them to do their regular checkup, etc. But how is palliative care different from
Yeah.
the medical attention that is given?
So palliative care is very different, but there's something that you had said just now that triggered a thought that is something I should have mentioned before in terms of compassionate communities and the number of people who need palliative care globally. Um, there are countries, including the Caribbean countries, we sign certain documents that say that we want our health systems to function in certain ways. So we want, when people access services, they're supposed to get particular things. And there's something called universal health coverage, which means that people in countries should be able to access the care that helps them to survive, to benefit in terms of rehabilitation, achieving cure, and in that definition is also achieving palliative care at a cost that does not cause them to be to experience catastrophic hardship. So I want to say what part of the role of the church is probably to help to partner with government as well in helping them to provide the care for their citizens at a cost that the citizens can afford. So what's the difference between palliative care and regular allopathic medicine? So suppose you go, although it's part of it, if you go to the doctor, say for example, you have a flu, and you go with particular signs and symptoms, your doctor is going to give you something to treat those signs and symptoms, and you are going to get better. Yes? And when you get better, that link with the doctor stops for that length of time. Yes? You had a particular thing, it was identified, it was cured, the interaction may stop. You may have an interaction that may be preventative. So you may go to the doctor may educate you about something, you take that knowledge and you go away, and the interaction stops, so to speak. The palliative care interaction, we're often interacting with people who are not necessarily going to be cured. Maybe over years, they're still dealing with a particular thing. And the interaction with palliative care tends to be more constant, and it tends to be more supportive, and it tends to be, even in one interaction, the assessment tends to be more holistic. So the doctor you've gone to the doctor for a focused medical examination, they're going to ask you about your cold and the history and the things related to your cold. But when we are taking a palliative care history or palliative care assessment, it's going to be more holistic. It's going to touch on several checkpoints during a particular interaction, and it's very much walking with a person across their lifespan, across the journey of an illness. And certainly we do feel the responsibility to make sure that should a person pass away or die, they are going to have that point contact and that support, their relatives, they're going to have that support going forward, even for a discrete period of time. Yeah. And I would say also that for uncomplicated medical interactions, they're going to tend not to be multidisciplinary. They're not going to tend to involve a lot of people. But even for sometimes the very basic, simple palliative care interaction, it is going to involve a lot of experts trying to get what is necessary for that patient. Because, and then the other thing is the length of time of the first assessment. Sometimes you might see a doctor, and quite frankly, it could be a short interaction for them to figure out and to prescribe. It might be 15 to 20 minutes. Sometimes, the first interaction for palliative care may not be as short as that, depending on the patient's energy level.
So what
Does
I'm
that help?
saying, sorry if I cut
Yes.
you, but
No, it's asking if it helped.
yes, certainly.
Okay.
But there's something that is looming in my mind. I like the quality. It sounds to me as though we're talking about real quality care. But associated with that seems to be a pretty expensive venture. You're
Oh,
talking about experts, you're talking about physiotherapists, you're talking about occupational therapists, you're talking about primary care physicians, you're talking about all these kinds of things. And healthcare is not an easy thing. So how does this work?
it doesn't have to be expensive. This is the thing. What we would want is for every physician every primary care doctor, every general practitioner, everybody to have basic palliative care skills. And if everybody is doing basic palliative care skills and your physiotherapist is clued up and your occupational therapist is clued up and your government has a supportive network, you can actually access these services if the health system is designed properly, relatively free of cost. So that's why we are pushing so hard for palliative care education, broad-based palliative care education in medical schools, in nursing schools, pharmacists, and everybody, so we can learn to work together as a team, so that we can start to change our thinking, so we can do more holistic assessments, and that governments in the Caribbean and so forth, we can catch up in terms of the persons who our citizens can access free of cost. So occupational therapy, physiotherapy, nutrition support as part of the basic basket. Now, if you have a country where those things are not part of the basic basket, it's going to be challenging. But if we can start to say, hang on a minute, the basic basket is no longer just the basic basket of healthcare provision is no longer just your GP and your community district health worker, nurse, and your environmental health officer. And we understand that it's more than that, and it has to be more than that, because our people in the Caribbean, we are suffering from illnesses that will have palliative care trajectories. So if you have heart failure, you're going to need palliative care. If you have had a stroke and you are likely to have another, or recovering, or you have advanced dementia, if you have cancer, etc. And these are the things that our people are suffering from. So we cannot just stay in the realm of having the district nurse that goes to the school and provides the vaccines, etc., or talking only about infectious diseases and so forth. We need to talk about infectious diseases, non-infectious diseases, and how non-infectious diseases progress, so that we can talk about palliative care provision. And I really do see that our network, I know that I'm primarily speaking to persons of Seventh-day Adventist faith, we have such a beautiful network of services that can be augmented to provide palliative care. We have many of our conferences may have Adventist Health Professionals Associations. You know who your nurses, your doctors are, your occupational therapists, your physiotherapists. If you don't know in your island, you may know in another island. You have your community services, men's ministries, women's ministries. Could you imagine if the personal ministries department decided to train through the department of the health department, the persons to go out and to partner with their district polyclinics or health centers to help families to understand how to care, and how to, if the care is beyond what the family can provide, to help them to understand who to call and how to call them. And it would be phenomenal if we could actually do something like that. I think it would be transformative. Anything from helping people with their personal hygiene once a person is appropriately trained. And even we have something called sitting palliative care services and day services, where people come out of their homes from 10 o'clock to 3 o'clock. And they may be able to interact with a doctor on that day, a physiotherapist on that day, have a meal, play games, socialize, and then they go back home. It's just mind-blowing if we were supposed to adopt this. And there are some interesting models, low resource models in other territories, I think particularly of Kerala in India. And you can see how community services, including faith-based community services, can be galvanized to deliver palliative care, or help governments deliver palliative care in ways that are useful.
I didn't realize I was muted there. I'm saying very interesting stuff. You have given some excellent ideas there, ways in which the church can take a greater role, and I hope the health directors are listening, because health secretaries in the respective churches are listening, because these are meaningful ways. You mentioned, community services, women's ministries, etc. And I think the church needs definitely to play a greater role in bringing comfort. My understanding of the gospel, is good news, and good news is multidimensional. But I want to get into the area of the patient who is getting the care a little bit. I realize our time is slipping away. I didn't realize I was moving so slowly. But the individual living with a life-changing illness can have significant emotional challenges.
Absolutely.
It seems to me that palliative care addresses the emotional aspects of the
Yeah,
patient.
it does.
Um, and the emotional component, I understand, is related to sorry about that, to the physical.
Hmm.
So what's the relationship there? And how will palliative care help to relieve the overall wellness component of the patient?
Yeah, for sure. So what we do know is that, say for example, if we take something like pain and the ability to cope, um, that your understanding how your body understands and how your body interprets pain, how you're able to cope with the challenges that you're facing, all of that can be impacted by your level of emotional strength and or stability. And what we would want to communicate to persons is that it is tough, it is difficult, and people might be walking through very dark places in their lives. So some people talk about going into the cave and walking with the patient through the cave, through the darkness, so to speak. And it is accepting the difficulties and finding ways for the person to unpack what they're feeling, what they're experiencing, and not necessarily just like covering it with a pretend band-aid, but unpacking the issues that they have and giving them the psychological support. So if you're oftentimes if your emotional pain is not well controlled, it's very common to hear a patient say all over me is hurting. They can't localize the pain because literally all over them is hurting. Or sometimes if you have a patient who is emotionally distressed, we know that there's a nerve, that one of the cranial nerves, the 10th cranial nerve, the vagus nerve, it is very important in terms of how people breathe, how their blood pressure is controlled, how their tummy feels, etc. So for us, understanding emotions is very important, and we don't stand at the bottom of a patient's bed or anything like that. It's sitting with the patient, sitting at a level. The communication strategies are the way how we speak, the tone of our voice, the body haptics, the way how you move your body and everything is different. It says that I'm here with you. I'm not in a rush, and let's see if we can work this through together. So for us, being present is important, and sometimes we may even touch might be important. So sometimes some people haven't been touched for a long time, and they just want somebody to be there to hold their hand or to sit with them in silence as they cry and those kind of things. And it's a lot of it is really about dignity and value. So emotions are important. You might not be able to, there are some tools that you can use to measure the emotion or etc. to kind of gauge where a person is at. So emotional assessment is important and is a big part of the pain assessment as well. And what you may find in palliative care is sometimes a lot of persons have a dominant emotion of fear or anger. Like, why is this happening to me? Am I being punished? Especially in our region where there's usually a religious overtone. Is God angry? Am I being punished? Why is this happening? Are my prayers going to be answered? Are my prayers not going to be answered? I'm not going to be the miracle I hoped I would be. All of these kinds of things. Sometimes you need to sit down and to spend time unpacking the emotion. And in terms of fear, sometimes fear can be very paralyzing. It can disrupt sleep. It can disrupt eating, etc. So we try to handle emotions as far as is possible. And sometimes there are some persisting emotions that can move into things like mood disorders where people have anxiety and depression and so forth, and some of that needs addressing at another level as well. So emotions are very important in palliative care. Yeah.
Well, now, um, you in your response just now, you started in fact by talking about, the whole matter of comfort, wanting the patient to live with maximum comfort and the relief of pain. So I think you specifically mentioned improving the quality of life for the individual. I sometimes wonder, can two persons be exposed to the same intensity of pain and they feel it differently?
Absolutely. Yes. They can be exposed to the same stimuli. So say for example, the same pin at the same pressure
Mhm.
and experience it absolutely differently. And I think that is, sometimes one, we all have different nervous systems, etc., but also the modulation that occurs in other parts of the brain in terms of how we appreciate the stimuli is different. And if your emotions are dysregulated, it's harder to interpret that stimuli as being something that you can actually handle. So sometimes if your emotions are dysregulated, etc., the stimuli may feel more intense than another person, etc. So
So,
yes, we can all have the same stimuli and experience it totally differently because we're different. Yeah,
so it's very important then that, you try, I'm thinking in terms of the delivery of care for palliative care, that you try to make the patient as emotionally comfortable as possible.
absolutely, absolutely. Yeah, yeah. So say for example, if I'm walking through a real case, if and refer to the patient. The doctor might give me the baseline information. I mean, if a person is in hospital, with the permission of the doctor from the hospital, I might go in from the community to meet the patient. And in my assessment, I'm going to be trying to figure out all the things that are important for them while we set up at home. And sometimes this just not just fear of physical feel of some people might be afraid of pain, but they're also afraid of the unknown. And sometimes what, as Bajans will say, sometimes what you don't know can hurt you more than what you do know. And some persons are afraid of dying, just downright afraid of dying, what it might feel like. And some people, depending on their belief, they're fearful of what might happen after as well. In terms of if they are ready for, according to their belief, heaven, hell, etc., and fear of losing out on things that would happen in the future that they are not going to experience. So, graduation of a child, the birth of a grandchild, all these kinds of things. These things are very important in the palliative care interaction as well. So it's just not the physical. It really takes into consideration the holistic form of care, and the goals are determined to a very large extent by the patient and their relatives in
I, I,
terms
wa-
of what is going to be achieved.
I want to venture into the area of ethics now. In a class I teach with um, Christian ethics for healthcare workers, there's the issue of healing versus cure. So what I hear you saying is that palliative care has more of focus on healing than a focus on care. Am I correct?
I don't think it's fair for me to ask you what you mean by healing.
Okay, so
Okay,
I'm making a distinction between healing and cure. To say
so
that, to say that, when you think of cure, if I have a particular condition, and let's say I have the flu.
yeah,
You mentioned that earlier. And perhaps I can get treatment for the flu, and the condition is no longer. So cure would be that I no longer have that particular illness. Healing, on the other hand, would relate to a more mental state, because I could be um sick but healed. In other words, I can bring myself to acceptance and understanding, and
okay.
I'm able to relate to life better, and to live with comfort, even though I may have some restrictions.
Yeah. So then in that case, I agree that the
Okay.
emphasis would be on the definition of healing as you think. But I was concerned because some people think that that healing occurs when you have been restored to a complete level of soundness.
No, that's
Right.
not. That's not.
And you cannot, in some cases, you might not revert to your baseline, but you can have maximum. The goal is to have the best possible experience with the level of soundness that exists, but it might not be completely to your baseline. So that's one of the trajectories in palliative care. On one of the graphs is that, like, say for example, you may have a pneumonia because you have like a chronic lung disease. You never maybe return to your baseline. You may dip. You might come into hospital, but then you may come back up. But you may never return to the pre-baseline before. But you can still have joy. Yeah, you can still have fulfillment. You can still have maximum experiences, even in the context of challenges. Yeah. And it doesn't mean that every day will be great or every hour will be great. There will be challenges, but there's a team that is working along with you to help you to cope with those challenges as much as possible.
That's
Yeah.
precisely the point I was making. Yes.
Yeah, for sure
Now,
then.
to continue on the ethical aspects, some conditions may be so complex that treatment can be very expensive. How would you advise a patient in a situation where he or she sees no prospect of cure, but whose treatment will lead to significant economic challenges? And let me tie this in. Somebody just asked, because I know this week in the news, the UK, was it yesterday, I think, just approved the law to legalize assisted suicide for terminally ill patients. So that some persons may say that, in fact, let me, somebody was asking this question, so let me say that they said that the UK just passed a law. I actually dedicated a news item regarding assisted suicide. What is your view on this as it relates to palliative care? And my question was, in terms of an individual saying, listen, I know I'm not going to survive this. This is just wasting the time of my therapist, wasting the time of my physician. I want to end my life. How do you relate to all of that?
Okay, so there's several layers of answers. So have I experienced this? Yes. Have I experienced this often? Yes. Persons can get very frustrated with living, especially when we first meet them. And they may ask you, their relatives may ask you, and they may, especially in the Caribbean where we do not have legislation in support of physician-assisted dying or euthanasia. We do not have these laws that exist. So we cannot do these things in the Caribbean. Yes? So that's one thing. But usually what we'll try to do is to understand why the person is feeling this way. And sometimes the reason for why the person is feeling this way, it really amazes you. Sometimes they feel like they're a burden. And if they were gone, their relatives wouldn't have to worry, their relatives wouldn't waste money, etc., etc. But if you can, once you start to explain, etc., what might be possible, and get to sometimes the root, sometimes there's a fracture in a relationship and different kinds of pain. The experience that I've had is that people who once ask for death, etc., they don't afterwards. So I've not had a patient who has persisted. And then my other answer would be, my approach to this kind of situation would be not to do something that is illegal within the context of the legislation, the medical legislation that I prescribe to. Some of the things that we're even a little bit behind in the Caribbean is something called advanced care planning, where people can articulate, etc., what they want to happen to them should they lose the ability to make decisions for themselves. Some of our islands, we don't have that legislation in place. And we need to catch up so that people's rights in terms of what we might call futility of care, doing things to patients that are not necessarily are not going to improve their lives. So that's one of the things that I can say that I do. If there is something that a relative is calling for in particular that is not going to help a patient, that is actually going to worsen their life and might hasten death, even if it does not appear that way on the outset, we definitely cannot do that. So say, for example, a person is dying, they might be actively dying, and they're no longer eating, they're no longer drinking. This is a difficult one to bring up just with 5 minutes ago, but this is one of the classic things that happens. So granny is no longer eating, she's no longer drinking. Maybe she had a heart condition, or cancer, or stroke, or something. But she's in the last 24, 48 hours, she's not drinking because she's actively dying. Her heart rate is dropping, etc. And the relatives may say, isn't she going to get dehydrated? Should we put up a drip on her? Yeah, because she might become dehydrated and she might be thirsty, etc. And what we would want families to understand in those conversations is that the body is not going to be experiencing thirst right now. Grandma is dying. If we put up something as simple as classic normal saline, salt water, sterile salt water in the drip, that's not going to benefit her body. Her body's not going to be able to use that. That might actually make swelling, what we'll call edema, like the ability of water to stay in the blood vessels is not going to be there. So something as simple as a drip, where the family might be thinking might be helpful, you as a palliative care practitioner needs to know that if I put up this drip, I am going to hasten this person's death, because that saline is not going to stay in the blood vessels where the relatives want it to stay. It's going to go into that person's lungs or something like that. So yes. So to answer your question, people who usually want, sometimes, in my experience, people who may sometimes ask for help in dying faster than is necessary, something else is going on. And if that something else is addressed, oftentimes it can be addressed. Palliative care, by definition, seeks not to hasten death, and it does not seek to prolong suffering, so, or cause suffering in the first place. So simple things that sometimes a relative may automatically think will help. You as a physician, you need to know even when your actions, your unintentional actions, may worsen a person's quality of life. So to answer that person, no, physician-assisted suicide is not something that we practice. It's something that I'm not seen as being necessarily, as not being necessary in my practice, but I know that there are other jurisdictions, Canada, etc., and persons may see it necessary there and it's legal there, but it's still not legal in the Caribbean. But what we do want, though, is we do want persons to have autonomy and some level of self-determination according to the law, and for the ability of their rights, etc., to be respected at the time of after, when they've lost their decision-making capacity. And we also want them not to have interventions that will prolong suffering. Yes, even when they seem simple.
Now that, I mean, you just raised a lot of questions in my mind there, because, interventions that may prolong suffering. Are we talking about palliative care? And I think one of your underlying goals is to improve the quality of life, to reduce pain, right? So when you have a patient who maybe, because there's a relationship between the hospice care and palliative care, when you're pretty sure that this patient is going to die, they may live for another 6 months or so, and 6 months is a long time in some instances. It may provide time for the family to deal with issues of closure and that kind of thing. But the person is going to die. The relatives may be considering, okay, especially if there is, this patient may need assistance to breathe, if they have to go on a machine to help them to breathe, and if they are still experiencing sensation to stimulus, so they may be experiencing pain, one person may argue, they're going to die anyhow. Do we sustain them for another 6 months in a relative place of discomfort, or do we just say, let's forget it? I listened to the debates they had in the British Parliament, and I think, the way it was done was rather very interesting. It wasn't politicians arguing against one another. It wasn't one side against another. but they seem to have been very cordial in their approach. People sharing personal testimonies of their experience with their loved ones, etc., to try to come to common ground. Now, I do know that when things happen in certain jurisdictions, they tend to trickle down to our area. So while it is very clear in my mind that it is illegal here, I'm not going to be surprised if another 5 years from now, our parliaments are debating a similar bill. Um, but in terms of palliative care and the delivery and wanting to meet your goal, do you get to a point where you say, hey, we can't do anything else for this patient?
Okay, so there's two things that you would have said. The whole concept of let's forget it, right? So we're not going to do that. In terms of, we wouldn't use that terminology. We would always want to make sure that we are doing our absolute best for the patient. And there is something in palliative care, almost like a mantra, where you're saying there's always something that you can do, but what you may do looks different. Okay? So there's never really a point where you can say there's nothing left to be done, even if it might be just as simple as controlling the temperature in the room or holding a person's hand as they take their last breath. There's always something that can be done to help with whether the coping of the patient and or their relative, and something that can be done in a dignified way. I think what I would like to say is that we would need to have the cultural discussions to see how acceptable this is in our society. We would need to have make sure that it's just not a simple thing of saying physician-assisted suicide being legal, but also having the frameworks around in terms of people being able to make the decisions. And I feel like there's a crux of your question that I am forgetting to answer. But even if it were to trickle down, it can't just be a discussion in Parliament. It has to be a discussion at the realm of the society, and then to make sure that other things are in place. So is this in the context of making sure that people have access to good palliative care that's integrated in the system? Is this a situation where people have access to the medicines that they need to relieve pain and to relieve other symptoms that may be causing them distress? How can we have a conversation about people having intractable suffering and therefore taking actions to cause them to die if we have not put in place everything that makes sure that they can achieve comfort in the first place? So I think when the Caribbean has good integrated palliative care, when the faith-based organizations and everybody is supporting, we would then have a mature system that can really then take on some of these broader issues. And it's not impossible to accelerate the speed at which our system achieves maturity in terms of palliative care provision. But I would be heartbroken to see a situation where we have access to assisted dying, etc., and various other things, and not have the basics in place. I don't know if that helps, Dr.
Yeah,
Greene.
certainly, certainly. I'm sorry out of time because there's a lot more that we can talk about. But you have certainly said enough to raise awareness, and for those countries that do not have the emphasis on palliative care at the level that you spoke about this afternoon, I'm really thinking that, I mean, more of our churches, our health ministry departments, and maybe community services. I noticed the
Yes.
Union Community Director is on and commenting in the chat, Community Services Director. But perhaps we can do some
Yeah.
level of agitation, perhaps.
And training, education.
Yes. Yeah, and there's this matter you mentioned earlier, of partnering with government agencies. Collaborative approaches tend to work well. Sometimes some people sit down and think that government has to do everything, but
No,
if we work together, it can be
absolutely.
of significant benefit. So I'm hoping that for those jurisdictions where we are not where we ought to be with the level of palliative care, that um, something can be done from our churches, from maybe our health associations. As you mentioned, the Seventh Adventist Church has professional health associations in various jurisdictions, because it is a very important subject.
Yeah, I was sick and you visited me, you know?
That's right. And the reality is, one time I was 21, I'm not 21 any longer. We're all moving towards that period of time when we may not be as active and we may be in need of receiving some of this kind of care ourselves. But thank you so much, Dr. Graves. It
You're
was
welcome, Dr. Greene. You're
to
welcome. Thanks for
have
having
you
me.
back. Yes, certainly. Just want to say to our Let's Talk community, we will not be having Let's Talk for the next 2 weeks. You can consider that your Christmas break. When we come back, we have a very special presentation. We did promise that we are going to be dealing with uh, cannabis and the technical challenges we want to look into. In many of our jurisdictions, we have now decriminalized it. We will have an expert to go into the rationale why or how it impacts the human brain. So that's going to be very important. So listen out. We're going to take a 2-week break, but we're going to be back with some very good stuff. Thanks again, Dr.
You're welcome.
Perhaps I should give you a minute all the way over time, a minute just to leave a closing thought. There may be a burden on your mind. I know you're passionate about palliative care. What do you want to leave with our listeners?
Yeah, I would want to say that if there's anybody out there who this presentation resonates with, to know that there is help in the Caribbean. You can look up the Caribbean Palliative Care Association. You can try to find the palliative care provider in your island. And if you don't have a provider in your island, through the association, you just Google it. You can contact and we can try to help you. And I don't think that, don't let cost be a factor, the foremost thing in your mind, but think about accessing the knowledge and the connections, the resources that can help. And I would want to say that you matter. I'm going to echo some of the mantras. You matter to from the beginning to the end. And we're not going to be afraid of the end. We're not calling the end, but we're saying that palliative care can definitely improve quality of life for patients and their relatives. And for those of you who are faiths, varying faiths, think about how your faith can help your government or your health system to provide palliative care, especially community palliative care, so people can have something that helps them to improve their form of life in a location that they can access and be benefited. And that's what I would want to say. I think as Caribbean people, we don't have a lot of resources like some other countries, but if we unite, we can get it done. And I think our church, our Seventh-day Adventist church community in the Caribbean, can be a unifying force to help accelerate palliative care provision.
Thank you so much. That's all
You're
for today.
welcome.
May God bless you all.
Thank you.